topic for discussion is asthma. Asthma is a chronic inflammatory condition usually characterized by a reversible or recurrent obstruction of airflow. It is due to most commonly because of hyperresponsiveness to any stimulus, any airway hyperresponsive to any stimulus, which is the hallmark of asthma. Usually asthma affects about 10 to 12% in children and about 15%, 10 to 12% of adults and 15% of children. In Western countries, asthma is usually one of the major hindrance for kids to go to schools, and it is actually an economic burden also because of multiple number of leaves and kids not going to school, etc. So it is usually one of the most commonest airway obstruction disorder also. It leads to bronchospasm, mucosal edema and mucous plugging of airways. Usually other hallmarks for them is initiation of any injury where there can be repair and remodeling can be seen in these cases. And hyperresponsiveness of this airway is also another hallmark condition of this asthma. This picture usually is showing where a normal airway and during an asthmatic symptoms how the airway is actually disturbed. In normal airway, what happens, a muzzle and airway wall are usually normal in condition. But where a patient is having asthma, the airway is usually narrowed and there will be mucus plugging can also be seen, and inflamed or thickened airway wall can be seen here. And there will be a tightened muscle which usually constricts the airway, and patient will have difficulty in breathing whenever they have an asthmatic attack. And whenever there is an asthmatic episode, before asthmatic episode, normally the air sacs are usually normal in size, but when an asthmatic attack occurs, after an asthmatic attack, what happens is the airway sacs are usually swollen and the airway tract is usually filled with this mucus plugins. This will lead to difficulty of breathing in case of asthmatic patients. Usually the common risk factors for this asthma is there will be polymorphisms of genes in chromosome 5q. Usually that's the reason asthma is known to be a familial in condition. It runs through families, and the diet is usually low in whenever a patient is taking diet which is low in antioxidants or diet which is high in sodium or omega-6 polyunsaturates also, they'll be more prone to this. They actually act as risk factors for asthma. And when patient is exposed to any nitrous oxides or passive cigarette smoking and any occupational exposure to toluene and also any fungal amylase in wheat flour also, these also act as risk factors for this asthma. Asthma triggers are present, that is, there is some triggering factors which will cause this asthmatic attack. Usually these asthma triggers include cold air, whenever patient is exposed to cold air, or pets are present where the fur of these pets also can lead to asthmatic attack. Pollen grains, usually they are most common allergens in case of asthma. They usually trigger this asthmatic attack. And these pollen grains are usually most commonly seen in case of atopic asthma, where these pollens are they cause the hyperresponsive of airway, usually in already sensitized patient for these allergens. These pollen grains are another important asthmatic triggers. Some dust, smoking, especially the passive smoking, also act as a trigger factor for this asthma. Stress, anger, pollution, strong odors and any bugs that are present in the home or on the bed or on pillow covers, all these factors can trigger asthmatic attack in this patients who are prone to asthma. And in case of exercise also, exercise induced asthmatic attack can be seen, especially when these exercises are being done in open air or on cold air atmosphere. Then exercise can also trigger asthmatic attack. So what are the mediators that actually cause this asthma? The common mediators that cause asthma are histamine, leukotrienes, prostaglandins. These actually cause bronchoconstriction and they cause increased microvascular leakage and airway mucus secretion. All these factors, what they do is they constrict the airway and thus leads to difficulty in breathing. Interleukin 4, interleukin 5, interleukin 13. These three interleukins are usually the ones which actually mediate this allergic inflammation. Other pro-inflammatory cytokines include tumor necrosis factor alpha, interleukin 1 beta. These amplify the inflammatory response. These interleukins 4, 5, 13, they actually mediate, and in tumor necrosis factor alpha and interleukin 1 beta, they amplify this inflammatory response. Next, PAFs, kinins and adenosines, endothelins, nitric oxide, these are other factors which are also acting as mediators in case of asthma. Coming to classification, asthma is usually classified grossly into two types. One is extrinsic asthma and intrinsic asthma. Extrinsic asthma is also called as allergic asthma or atopic asthma. This usually have external mediators, that is external risk factors or trigger factors such as pollen, dust, pollution, cold air. All these are responsible for causing extrinsic asthma. Intrinsic asthma is something which is actually present within the body system itself, such as nasal polyps, stress, increased steroid secretions. All this can cause intrinsic asthma. Coming to allergic asthma, what happens is it usually is seen in younger age group. They actually have a positive family history, like it runs through family, this allergic asthma. Here what happens is patient is usually allergic to one known allergen. He or she is already sensitized to it, and on constant exposure to this allergen, what happens is asthma usually triggers. In these cases, what happens, there will be increased eosinophil count and IgE levels are also increased, and there also will be positive skin sensitivity test, that is they are usually allergic to that particular allergen. Allergic rhinitis, atopic dermatitis are commonly seen in these cases. Allergens are usually proteins that have a protease activity which can stimulate the inflammatory action, and they also have common allergens which are, as we discussed, pollens and dust, mites, insects, bugs, which are usually present, small tiny insects which are present on the pillow covers, on the bed, pollution, all these factors, dust, all these factors are common allergens that trigger asthmatic, extrinsic or allergic asthma condition. Coming to intrinsic asthma, it is usually seen in middle age. They doesn't usually have a family history. They're associated with nasal polyps and they're more severe. This intrinsic asthma is more severe when compared to that of allergic asthma. It is usually aggravated by emotional stress. When patients usually take aspirin also, intrinsic asthma is triggered, and this intrinsic asthma can respond well to steroids. Coming to exercise-induced asthma, it is aggravated on exposure to cold or dry air, and aspirin-induced asthma is precipitated due to excessive intake of this aspirin. Not even excessive. If patient is allergic to this NSAID, particularly aspirin, then we can see this aspirin-induced asthma. Coming to clinical features of this intrinsic asthma, they usually have these prodromal symptoms like itching under the chin. They'll have discomfort between the scapula, and they have some kind of fear which is inexplicable, that is called as impending doom. This can be usually seen in case of intrinsic asthma, and these patients usually have an inspiratory and expiratory wheeze. In asthma, what happens is expiratory wheeze is most commonly seen when compared to that of inspiratory wheeze. They have on auscultation, rhonchi can also be heard in case of this extrinsic asthma. Usually they have a predominant non-productive cough, that is they have cough but they don't usually produce this sputum. And in acute severe cases what happened is patient tries to gasp, they gasp for breath, that is they try to inhale more amount of oxygen because of this obstruction, and as the air usually cannot be inhaled, they have to take it with force. Patients usually get cyanotic, they appear blue in color, that is because of less amount of oxygen present in their circulation, and usually they also have altered consciousness because of this excessive intake of breathing. Excessive forceful intake of breathing, what happens is they lose consciousness sometimes, and they also have a silent chest. They usually hunch forward, that is to take that breathing with a forceful inspiration. They have this characteristic sign of hunching forward. Severe retraction with nasal flaring can be seen in these cases. Pulsus paradoxus can also be seen in these cases. So how to diagnose that patient is suffering from asthma is, patient usually the color of the patient usually changes in case of extreme or acute asthmatic condition. They become cyanotic. Have to check for vital signs and chest auscultation. Usually wheezing and rhonchi can be heard in case of when chest auscultation is done. Pulse oximetry has to be done. Complete blood picture, ECG also varies. Electrolyte levels usually vary in these cases. They usually show more amount of sodium. Lung function test and IgE levels, X-ray, PNS can also be taken in case of this asthmatic condition. Coming to management, beta-2 agonists are usually helpful in case of this, and ipratropium, tiotropium is usually given. Theophylline is drug of choice. Inhaled corticosteroids, that is ICS, are usually available. Patient can carry them in the pocket, and whenever there is an acute asthmatic attack, inhalation of these corticosteroids can be done. Anti-leukotrienes, sodium chromoglycate, anti-IgE immunotherapy are recent advancements in case of asthma, and especially in acute asthmatic conditions. In case of acute or severe asthma, it is a medical emergency where subcutaneous adrenaline of 0.3 to 0.5 ml in 1:1000 concentration has to be given. Usually with one dose patient usually comes to normal state again. If at all patient is not coming, give the same amount of dose after 5 minutes and immediate medical shifting to a medical ward or an ICU is usually important in these cases. Next, IV hydrocortisone of 100 mg, nebulized beta 2 agonist, oxygen, and chest physiotherapy has to be given. Artificial respiration has to be given in case of very severe or acute asthmatic attacks. Now coming to dental considerations, usually nowadays patients are these asthmatic patients are usually on this ICS, that is inhaled corticosteroids. Whenever patient is taking this inhaled corticosteroids, what happens is oropharyngeal candidiasis and petechia at the palatal region, especially the soft palate region, are most commonly seen. So patients have to be advised that after every pump of this ICS, after every usage of the ICS, what happen? Patient usually have to rinse his or her mouth and keep his oral cavity clean. And other thing is anxiety can also precipitate asthma. So whenever an asthmatic patient has to be treated, take an early appointments than giving them a late appointments, and operatory counseling has to be done to reduce anxiety. In severe cases, patient is so apprehensive, then any anti-anxiety drugs has to be given, that is pre-medication of these anti-anxiety drugs before the surgical procedures or any elective dental procedures has to be given to these cases. When patient is on ipratropium, usually they have dry mouth, to prevent this dry mouth or to address this dry mouth, any methyl cyanacrylate can also be given. Methyl cellulose can be given in these cases. Then we also have, in case of severe asthmatic conditions, what happens is GA, general anesthesia, or nitrous oxide inhalation has to be usually contraindicated. But if the condition can be what happens, relative analgesia with nitrous oxide or oxygen is preferable when than sedation with diazepam. Whenever they are thinking of surgical considerations, think about GA. Usually GA is contraindicated in these cases. Then we can go with relative analgesia with nitrous oxide and oxygen combination can be given in these cases. Thank you.